Scott.
Good morning, my lady. May we call Kevin Rowan, who can be sworn?
Mr. Rowan, if you can please repeat after me. I do solemnly, sincerely and truly
I do solemnly, sincerely and truly
declare and affirm
that
the evidence I shall give
the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth and nothing but the truth.
the whole truth and nothing but the truth.
Thank you.
Thank you.
Good morning, Mr. Rowan. Would
Morning.
you please give your full name?
My full name is Kevin Rowan.
And you are the Head of Organisation and Services Department of the Trade Union Congress, is that correct?
More or less, I was till about a month ago. I now have a new role, but thank you, yeah.
Okay. And in terms of that role, which I think was the role that you gave when you provided the statement to the inquiry, could you provide a very brief summary of what that role entails, please?
That role heads a large department in the TUC which covers a range of policy and campaign areas, including across all public services, health and safety, trade union renewal, and a few other things, but they're the main kind of core elements.
And was it as part of that role that you were a non-executive director of the HSC from the 1st of June 2016 until the 31st of July 2021?
Well, there's a relation between the engagement with the health and safety executive, but non-executive board members are appointed in an individual capacity rather than on behalf of an organisation, but there's direct relationship.
But it wasn't a de facto role?
No.
Mr. Rowan, just to contextualise the questions I'm going to be asking you today, so I hope you forgive me if I don't ask you any questions about the structure of the TUC. You set that out in detail in your statement, and also her ladyship's heard that evidence, I think, in the previous 4 modules. We've also had Miss Gorton's evidence last week about engagement forums and partnership arrangements. So I want to focus with you on health and safety protection. You heard Mr. Brunt's evidence from last Thursday. Is there any comment that you wish to make in relation to that evidence?
I think the one particular issue that struck me with listening to Mr. Brunt's evidence was around his response to the purpose of RIDDOR reporting. He seemed to imply, and it's my impression of his evidence, that RIDDOR was principally a benefit for employers in their efforts to manage health and safety in the workplace. While I think clearly there's all employers who end up in a situation where they have to exercise a RIDDOR report, there needs to be a learning from that, a review of their health and safety management practices. But there's a step before that employers, all employers need to undertake, and that's a risk assessment. And the risk assessment should inform the health and safety management regime of employers. RIDDOR is effectively a scenario where that health and safety management system has failed, where someone's been injured, made ill, or where there's a dangerous occurrence in the workplace that could have led to a serious injury. So I think the bit that I thought was I'd have liked to have heard from the health and safety executive was that the RIDDOR reporting should trigger evidence to the health and safety executive for them to act in an enforcement and regulatory action, because it's evidence of an employer failing to manage health and safety in the workplace. So RIDDOR is absolutely useful in terms of it's a test, if you like, of the employer's health and safety, the duty holder's health and safety management, but it should also be an alert for the regulatory authority.
So it's more...
Sorry to interrupt. Can I just challenge one of your statements, if I may, as a non-expert in this field, Mr. Rowan? You said that if someone becomes ill, that indicates that there's been a management system failure. That's not necessarily so, is it? Someone might become ill and it may not be the employer's fault at all.
No, absolutely, my lady, that's right, but it's an indication that there could be something wrong with the management health and safety system.
So they need to investigate.
Exactly so.
And so it's effectively, it's a 2-stage process, isn't it? RIDDOR making the report identifies to the employer that something's gone wrong because the employer feels that a report has to be made. And then there's a second stage which alerts the regulator, and then it's up to the regulator to have a much broader systemic view. Is that an encapsulation of it?
That's how it should happen, yes.
Before we deal with the RIDDOR system and getting into any great detail on that, you said that you were a non-executive director. What is the benefit of having independent directors, non-executive directors within a regulator such as the HSE?
Well, I was an employee representative on the board of the Health and Safety Executive, and the value I think that I brought in that role was a direct connection with, in my case, the kind of trade union movement, and if you like, therefore, a direct connection with trade unions and a direct connection with workplaces and working people, and I could bring to the board, if you like, the insight of that network of health and safety representatives who voice concerns around health and safety issues at a workplace level, and bring that kind of, if you like, perspective to the strategic and operational decisions that the Health and Safety Executive takes. Similarly, there would be employer representatives on the HSE board and independent members, sometimes from academia, sometimes from other sectors.
Because we've seen from the statement from the Health and Safety Executive in Northern Ireland, the statement about the Health and Safety Executive in Northern Ireland, that for a number of years there hadn't been any non-executive directors in place. Would you wish to make a comment on whether that reflects a failing that needs to be remedied?
My view and TUC's view is that there's real value in that tripartite conversation happening at a strategic level in organisations like the Health and Safety Executive. I think the absence of those representative voices to inform, to challenge, to check the strategic operations of bodies like that, I think the absence of that, I think, is problematic. I think it weakens the organisation, and I think you see this in ACAS, you see this in the Health and Safety Executive, the Law Pay Commission, and I think the kind of feedback from all of those organisations is that they're more effective when they have the opportunity to hear those voices.
And just dealing with the devolved nations as a whole, so Wales comes within the auspices of the TEC as a whole. Scotland and Northern Ireland don't. They have their own separate structures. Again, I'm not going to go with the detail of that. Were you having discussions with your opposite numbers across Scotland and Northern Ireland in particular about the type of issues that they were facing in relation to healthcare systems in Scotland and Wales?
I mean, I don't think that I could say, in all honesty, that there was a systemic, consistent engagement with colleagues in the Scottish TUC or the Irish Congress of Trade Unions, but we would certainly speak informally on a fairly regular basis, particularly, I think, in scenarios like this when we're all, if you like, struggling to kind of respond to a hugely serious issue such as this.
And from your perspective, arising out of those discussions, as far as they related to healthcare settings, were there major differences across England, Wales, Scotland, Northern Ireland, or were effectively the basic concerns the same, even if there may have been nuances arising in each individual country?
I think the basic concerns were principally the same. Slightly different approaches in that in Northern Ireland in particular, I think relationships are much closer. So there's, in my view, and it's not my area of expertise, but in my view, there's a higher degree of collaboration simply because of the nature of that part of the world. Everybody knows each other really well. It's quite a small community in relative terms. In our experience, in our kind of reflections, if you like, looking back, we weren't in a position where we had the same level of relationship or engagement with government, certainly in the UK. So that was different. And I think similarly in Scotland, relations between the Scottish Parliament and the Scottish TUC were much closer, if you like, than I think we had with our Westminster government.
And was that, just to make sure I'm focusing on the right issue, was that just in a healthcare setting, or was that across all sectors?
For us, I think it was across all sectors.
Okay. I'm going to steal a line from Mr. Jacobs last week when he said to Mr. Brunt, rather than niceties of RIDDOR, let's focus on what needs to happen in the next pandemic. I'd like to explore with you about, in healthcare settings, in the event of the next pandemic, what should happen, what your view is in relation to reporting and regulators and the actions of the regulators. So do you agree with Mr. Brunt that RIDDOR was not intended to be used in a pandemic involving thousands of instances of infection? It was really designed to capture single one-off unexpected events, accidents and incidents.
No, I don't agree. I mean, I think, and if I got a little bit of leeway to respond to this, I think there are three stages, I think, that have been exposed as flaws in our health and safety system. I think certainly the first point is identification of data which would alert both employers and regulators to the existence of significant risk. The way that the report RIDDOR was actioned, and the way that employers were advised around RIDDOR, so the argument that they needed medical certificates around COVID-19 meant that there wasn't the gathering of intelligent data about the presence of risk of COVID-19 exposure in workplaces. In my view, that is what RIDDOR should do, because what RIDDOR does is it gathers data about risk beyond the workplace level, because it's a report to the health and safety executive. So that's the first thing. I think that would have informed, or should have informed, that healthcare settings, with the emergence of the pandemic, then became a high-risk sector. So the intelligence will provide evidence of risk. Gathering that intelligence in a systemic way would identify sectoral risks. That would then inform the health and safety executive's enforcement strategy. And HSE's enforcement strategy is very effective when it identifies a high-risk sector. There's an enforcement and inspection regime which results in significant impact in those workplaces. A 40% material breach rate is about standard. That's where an inspector will identify a material breach of health and safety law in 40% of cases.
Sorry to interrupt, Mr. Rowan. I appreciate the call flow. It's just that you're going very quickly. I've got a feeling I might get some complaints from the stenographer.
Oh, my apologies to the stenographers, my lady.
Sorry, I interrupted you.
No, that's
where
all right.
An inspector will identify a material breach of health and safety law in 40% of cases.
Yeah. So if you have the data point starts in workplaces where employers identify where health and safety regulation in their own management systems has broken down, that leads to a RIDDOR report. The RIDDOR report is then collected by the health and safety executive. That would have identified the health and care sector as being a high-risk sector. That should have then informed a health and safety executive operational and strategic approach, which would have resulted in other high-risk sectors, inspectors identifying material breaches and issuing enforcement actions to correct those breaches.
Can I just ask, Mr. Rowan, a very helpful explanation. In your view, did RIDDOR work in terms of reporting incidents within the healthcare system during the pandemic?
I don't think RIDDOR worked anywhere near as well as we would like it to.
Is that a structural issue?
I think there are a number of factors. One is, I don't think most employers generally understand the duty that they have under RIDDOR. That's one factor. Second factor is, I think they were given advice that unless there was a medical certificate proving that that COVID was contracted, they didn't need to produce a RIDDOR report. And thirdly, there was the issue of cause and effect. We know that there was a lot of contraction of COVID in non-workplace settings, and it's not always going to be absolutely clear that COVID was contracted in the workplace. But I don't think that employers were encouraged or particularly enabled to provide evidence of COVID exposure in the workplace. So I think there were three failings in the RIDDOR system, which, if the first thing that you need to act is data of risk, there are three different factors that prevent that data being produced. So straight answer is that no, RIDDOR didn't work in the way that we would want it to.
Okay.
So are you saying that, what's the timing for that comment, Mr. Rowan? So in the early days, obviously there was a great deal of uncertainty, whether or not people could get tests. When do you say, are you saying it didn't work throughout the pandemic, or are you saying that it was when the uncertainty had gone and people could say whether or not they actually had COVID?
I don't think it worked during the pandemic, lady. I think, and my understanding is that the guidance around RIDDOR changed a number of times during the pandemic, which wouldn't have helped clarity for employers in what they report. But we've seen very little evidence of RIDDOR being the mechanism that then informed regulatory or enforcement action. So I find it hard to identify a scenario where RIDDOR has worked in this inquiry question.
Well, then, let me ask you three different options, and you may tell me it's none of the three. Could RIDDOR work in its current format? Is option one. Option two is, could RIDDOR work, but actually does need effectively to be rewritten to deal with the pandemic? Or number three, do you need, in a pandemic time, something separate to RIDDOR, which does a different job but has the same aims?
There are three different questions. I think for RIDDOR to work well, it needs to be clear, understood, and employers need to respond to the duty under RIDDOR. For a long time, we've been reporting that RIDDOR produced significant underreporting of health and safety risks generally. So it doesn't work in its current format. To answer the last question first, if I may, and I think, to be fair, we were all learning about the COVID pandemic and how risks were, how infections were being spread. A sensible approach would be to say, where we're unsure about kind of those airborne viruses or how viruses are transmitted, the most safe approach would be to gather as much data as possible and to share that data as early as possible. I don't think that was the case with RIDDOR. In fact, some of the guidelines, particularly around things like medical proof of COVID, actually dissuaded employers from gathering and reporting that evidence. So I think that there's certainly the indications would be you need a specific approach to managing those risks in a pandemic. I think there's a specific set of circumstances that would apply in that. So I guess yes is the answer to your third question. I think you need specific circumstances for specific hazards.
Because this comes back to your point, doesn't it, in terms of the breadth of the view of the regulator, that it would have much wider knowledge if it's receiving RIDDOR reports from across the entire country, or England and Wales, rather than individual employers who are making individual reports who may have an understanding within their own employment area, but a regulator should be able to identify more than that.
That's absolutely right. If you don't have intelligence from, if you don't have data, that you can't have intelligence, and if you don't have intelligence, you can't act. And the systemic process by which you identify and gather that data and intelligence to then inform your actions was absent.
Because I think it was, again, Mr. Jacobs was saying on Thursday that healthcare settings in a non-pandemic time tend to be considered low risk because they're well aware of infection risks and control. Don't they then switch to high risk when you're in a setting such as a pandemic where you have a novel infection that's spreading in a way that people aren't entirely certain about?
It seems to me that, I mean, certainly it is the case that because of the regulatory nature of the healthcare sector, there are procedures, there are processes, people kind of tend to work within a very regulated system. And they are low risk. I mean, there aren't, to my understanding, huge numbers of incidents of injury or ill health spread amongst the healthcare workforce generally. In a pandemic, and I think this was especially evident when we were hearing about failings around protective equipment, any logical assessment would identify that relatively early as a potentially high-risk environment. And that should have, in my view, led to a review of the Health and Safety Executive's regulatory priorities. It's very effective organisation in high-risk sectors. What my concern is that it didn't pivot to treat the healthcare sector as a high-risk sector.
Do you think that every infection of a healthcare worker should have been reported to the HSE?
I think, given what we know about the exposure to risk, that it was a high-risk setting, that there were huge problems with personal protective equipment, and the potential risk to individuals, I don't think it's unreasonable that an employer in that setting should be required to record and report incidents of COVID, all incidents of COVID.
And is it fair that simply because there's been a report that there doesn't necessarily have to be an investigation? It can simply be that you're recording information about the circumstances of that individual, in this case, infection.
Yeah, I think that's fair. There'll be scenarios where people working in the healthcare environment that don't have direct engagement with patients who have COVID will contract the virus. People working, in kind of ancillary roles often will not come into direct contact with patients. But it's important that they're recorded, because we also know that people working in those, if you like, less direct roles were less likely to be in the front of the queue for personal protective equipment. So their risk of exposure would have been different to healthcare workers in the front line. So it isn't, but their lives are equally valuable. Their health and well-being is equally valuable. So it is important that when they do contract, if they do contract COVID-19, that is recorded. And it may be that would then inform the health and safety management practice of those employers.
Because without those reportings, based on your experience within your role at TUC and as the non-executive director of HSE, are you actually able to track all the various different groups? And I mean that whether it's just protected characteristics or the equivalent Northern Ireland or otherwise in terms of their job role. Unless you know who's been infected in a healthcare setting, how do you actually know effectively what the impact is and where people are getting infections from?
No, that's exactly right. I mean, the first step any employer should do, and all employers have a duty to do this, is to assess risk. They should, in situations where those risks change, so when we have a pandemic coming into our society and our economy, they should be reviewing those risk assessments. if they're monitoring then the health of their workforce, as they should, and you may have a group of cleaning staff who again may not have been able to access personal protective equipment in the way that frontline healthcare workers, if that group of workers, a high percentage of them contract COVID, then you would need to look at your health and safety management system to make sure that those workers are protected. So unless you have that data, you're not going to know that you need to change your health and safety management practice. And the same is true when you take that above the workplace onto a sectoral or wider level. If the health and safety executive don't have the intelligence that sectors or groups of particular workers have a higher prevalence of exposure to the virus than others, then the health and safety executive has no evidence or intelligence to change its regulatory regime.
Going to take the next part in 3 different sections. First is going to be reporting, then there's going to be recording by the regulator, and then there's going to be investigation by the regulator. So dealing first with the reporting point. In healthcare settings, should there be any limits on what is being reported, do you think, in terms of whether someone suffered an infection?
I don't see a case for not providing as much evidence and information as you've got when you're dealing with a COVID pandemic that's killed tens of thousands of people. I just don't see how that's a reasonable approach.
Would that then extend to what should be recorded by the regulator about the information that's provided to them?
I think the kind of information that should go to a regulator, again, the more you limit it, the less intelligent decision making the regulator is able to make. So the more information you have, the better decisions you can make.
So factors such as ethnic group should be included?
We know that there were particular prevalence of the virus among certain groups of our community and certain groups of workers. And again, that would inform an intelligent approach to how you regulate and enforce amongst those group of workers. We know that ethnicity was a particular concern in the experience of COVID-19, exposure to COVID-19. We also know occupational groups were more or less prevalent to contracting the virus depending on their roles.
When you say occupational groups, would you also then be looking to record where they were actually working at the time in case someone's been redeployed, for example? We know from our experience that workers who were in more populated occupations or populated areas would certainly be more likely to contract the virus. So that was a factor. And there's an occupational, if you like, characteristic that would inform any kind of regulatory or enforcement regime. And as we've just been discussing, we know that the healthcare sector as a whole moved from low risk to high risk. So there are sectoral factors to consider as well as occupational factors as well as personal characteristics.
Can I interrupt? Can I just go back to the basics? If I'm an employer and I make a RIDDOR report, is there a form I fill in, or and if so, what information does that form require of me? Very roughly.
Yeah, so there's both a hard copy and an online form that employers are required to complete and that will detail the nature of the incident, the nature of the injury or illness that's right, and a description of the factors that the employer might believe have contributed to it.
So would it depend on whether the employer thought that ethnicity was a relevant factor?
I'm not sure I can answer that, Emily, to be honest. I'm not an expert in the report.
But ethnicity isn't necessarily a factor that has to be reported. So, for example, with the pandemic.
Sorry, yeah.
So that wouldn't have been, even if the employers had all been fulfilling the RIDDOR regulations, as you say they weren't, that ethnicity would not necessarily have come through. It depends on the employer.
I think that's right, Milady. I couldn't say with certainty, but I think that's right.
Do you need to record the same information from the healthcare system as you would from other sectors, for example, in the middle of a pandemic, or as you say, that the risk in the healthcare sector is maybe higher than it is in other sectors?
I think the reporting is standard across sectors as it currently operates. I think the point that we were discussing earlier is relevant in that we know that there was a significant increase in risk in the healthcare sector. So the kind of things that would have been normally recorded in any kind of RIDDOR investigation would apply to the healthcare sector. So things like provision of PPE, things like work systems, things like social distancing, and the existence of risk assessments and good management would be the kind of normal things that are recorded and reported.
But reporting may be standard, but does it need to be standard when you're talking about in the context of a pandemic to make sure that you're getting the best information?
No, I mean, I think because I think we were in a particular scenario where there was a new set of risks because of the existence of the virus, there was a need to record more data than RIDDOR would require. So what RIDDOR would normally demand is that incidents were occurred as a direct relation to something that happened in an occupational setting. I think for a lot of cases, a lot of circumstances, it wouldn't necessarily have been obvious that if someone got contracted COVID that had occurred in the workplace, but it may have done. So I think in these particular circumstances, it would be more important that employers were reporting incidents of COVID across the board rather than where they could directly associate the risk of exposure with something that had happened in the workplace.
Would you also be looking to record, or even this might not be something that was reported at the time when, in this case, an infection has been caused, would you be looking to record any long-term effects, such as long COVID?
I think that's important. As you know, we were, and to some degree still are learning about the longer-term impact of COVID, and there's ongoing conversations around industrial injuries benefit and whether this is a prescribed illness in the workplace. So I think gathering the evidence to support that debate and that discussion is going to be really important, yeah.
Do you think in the way that RIDDOR was applied to long COVID, do you think that there was sufficient reporting of instances as long COVID, or do you think it was underreported?
I think there's significant underreporting in all aspects, including the impacts of long-term impacts of COVID.
Moving then to the regulator has received this information. At what point should it look to start to investigate or take steps in relation to what information it has received?
So I think if the reporting system was working well, it would identify occupations or sectors that are more at risk of contracting the virus than other sectors. That should trigger a systemic response from the regulatory authority to investigate more, to inspect more in those sectors. So that would be one instance. I think where there's clear evidence of occupational activity, and that could be inadequate supply of personal protective equipment. It could be evidence of employers not following the guidelines that were issued to try and protect workers. Any of those incidents should lead to some kind of regulatory activity, some kind of enforcement activity.
Because what's the benefit in the context of a pandemic of having enforcement?
Well, the benefit of enforcement is fundamentally to correct poor behaviour or poor management systems that are there to protect employees. As I said, the HSE is extremely effective, in my view, in informing employers about the right way to manage health and safety, and to act as a check against employers who aren't effective at managing health and safety, and removing those hazards and making sure that employers do manage health and safety well. That's what saves lives.
How effective, in your view, was the Health and Safety Executive at actually carrying out that inspection and enforcement process during the pandemic?
Well, in my view, the Health and Safety Executive should have done was understand that the health and care sector became a high-risk sector during the pandemic and applied its very effective regulatory regime in high-risk sectors to the healthcare setting. It would have then led to more inspections, more engagement with employers, and would undoubtedly, in my view, have improved health and safety management in those sectors. I think you have the numbers, but I don't think we saw any increase in engagement between the Health and Safety Executive and the healthcare sector during the period of the pandemic.
Again, from your perspective, was that a capacity issue or not?
I think certainly there are huge capacity challenges in the Health and Safety Executive. The number of warranted inspectors has gone down dramatically in the last 10, 15 years or so. So the ability of the Health and Safety Executive to be agile and to respond to, if you like, sudden changes in the health and safety risks across the economy is limited. But we also know that the Health and Safety Executive stood down from proactive workplace inspections in that period. So I think there's certainly capacity issues across the HSE, but I'm not sure that's the only factor that informed, in my view, a lack of engagement in the healthcare sector.
Is one of those factors funding?
I think funding is absolutely a factor. I think the budget of the Health and Safety Executive has been halved in the last 15, 20 years, so it's huge impact.
And you're aware of, in terms of what was said to Ms Gorton yesterday about the Chair's understanding of funding positions, are there any other factors that arise in relation to the Health and Safety Executive and its way that it was carrying out enforcement?
I'm not sure that I'm really able to answer that. I mean, I think the Health and Safety Executive knows where it's very effective and how it's very effective. But I think, and I would agree with Rick Brunt's comments last week, inspections and enforcement through enforcement action is one, if you like, arrow in their quiver. They work with employers to provide good quality guidance and to develop good practice, and lots of kind of education of duty holders in that regard. But for me, the most effective way to correct employers who are not managing health and safety well is warranted inspectors. I've been on workplace visits with warranted inspectors. They walk through the door, employers stand to attention, they listen, and they act immediately when the warranted inspectors give them an instruction to do so. It's a hugely effective tool, and it wasn't deployed, in my view, as well as it could have been during the pandemic.
In terms of any future pandemic, does it follow that you believe that the HSE does have the tools and it's simply a matter of deployment rather than there are additional tools required?
I think certainly the Health and Safety Executive manages really well with the resources that it's got. But if it was to be required to respond in an agile way to a new and significant health risk, it would struggle to do that with the resources that it's got, in my view.
Does it have sufficient technical skills, or is there a bit of a grey area between it and an English example, the CQC, about the areas that it has oversight of?
No, I think it's probably the other way around. I think the Health and Safety Executive certainly has the technical skills and expertise to understand risks in the workplace, to understand what management controls are needed in the workplace, and to provide the advice and guidance to those employers to manage those risks.
So in terms of any lessons learned from your perspective about the way that the Health and Safety Executive was able to approach its enforcement functions, are there any recommendations or lessons that you think should be learned that haven't yet been learned?
Across the whole, because I think you have to look at this at all three stages. I think certainly the ability to gather sufficient valuable data about how COVID was impacting on workplaces and causing infection and ill health was systemic, a big, huge systemic flaw in my view. We didn't find the right way to gather data about where people were being made ill in the workplace. Secondly, that didn't then lead to an intelligent gathering of that data to inform decision making that then thirdly would have encouraged and enabled the regulatory and enforcement regime to pivot and operate differently to try and make sure that as few people were injured as possible.
My lady, given the breadth of the answers and the look forward in terms of the health and safety perspective, I have no further questions.
Oh, thank you very much, Mr. Scott. I think there is one question. Is it Mr. Foyer? There you are.
Morning, Mr. Rowan.
Are you switched on? Yep.
Looks, yes. I asked questions on behalf of a group of bereaved families in Wales. And I just got a few questions for you. In your written evidence and your evidence today, you contrast the relationship that the TUC had with the UK government and that of the relationship that they had with devolved nations. And you make reference to the term machinery being in place to allow regular dialogue between the TUC and the Welsh Government. Can you perhaps expand upon that and explain what was that machinery in place?
I can try, but perhaps, my lady, if we could kind of follow that up with the written statement, because it's not my area of expertise, but certainly my understanding is that we have a social partnership and social dialogue forum and arrangement in Wales where the Welsh TUC has, pretty close and pretty regular dialogue with the Welsh Government across the board.
And can you provide any practical examples on the ground where this dialogue with the Welsh Government led to a better health and safety outcome for healthcare workers in Wales than it did in England?
Apologies, I'm not able to provide that level of detail, but I'll happily kind of provide some evidence later if that's helpful.
Thank you. Lady, those are the questions that I had.
Thank you very much. Thank you very much, Mr. Rowan. That completes all the questions we have for you. Thank you very much for your help.
Thank you, my lady. Cheers.
Mr. Fireman.
Thank you. My lady, may I please call Miss Rozanne Foyer? she will affirm.
If you'd like to repeat after me, I do solemnly, sincerely and truly
I do solemnly, sincerely and truly
declare and affirm
that
the evidence I shall give
the evidence I shall give
shall be the truth, the whole truth and nothing but the truth.
shall be the truth, the whole truth and nothing but the truth.
Thank you.
Ms Foyer, could you please give your full name?
Yes, my name is Rozanne Foyer.
Thank you. You have given evidence before to this inquiry, but you've given a witness statement to Module 3. That's INQ 304111604. Can I just check you've got that accessible to you?
Yes, I do.
Thank you. You are the General Secretary of the Scottish Trade Union Congress, correct?
That's correct.
And we just heard from Mr Rowan of the Trade Union Congress, and I think it's clear, isn't it, that the Scottish Trade Union Congress operates in a very similar way to the Trade Union Congress?
Yes, we do.
Well, albeit, of course, its remit's in Scotland.
Yes, we cover over 500,000 members based in Scotland and have a similar range of affiliates who separately affiliate to the Scottish TUC.
Thank you. And with respect to the work that the STUC does, you've explained in your witness statement that it coordinates, of course, work that's done with health and social care unions, among other unions, in terms of their engagement with the Scottish Government and ministers and cabinet secretaries. Would you consider that, generally speaking, you have a good level of access to and liaison with the Scottish Government?
Yes, we have had a long-standing, close engagement with the Scottish Government. I would say that we have a high level of engagement. It's constructive and it's robust.
And did that remain the case during the pandemic?
I would say it became even more, the engagement was more intense during the pandemic and more regular because of the nature of what we were dealing with.
And you've set out in your witness statement that you agreed something called the Coronavirus Fair Work Statement with the Scottish Government. If we could just get that on screen, it's INQ 30107-242. And if we go to page 2, please. What we're looking at there are some principles that you have agreed with the Scottish Government in terms of how to approach the workplace and protecting workers during the pandemic. Is that right?
That's correct, yes.
And we can see obviously some of those, particularly those towards the bottom of the page, are particularly pertinent to healthcare workers, protecting the health and safety of all workers, particularly those on the front line. And of course, ensuring that workers are provided with clear and comprehensive information on work-related risks on an ongoing basis. How effective do you consider agreeing this sort of statement was in terms of establishing, I suppose, a sort of contract between the Scottish Government and workers?
The feedback we received from our member trade unions, including those in health and social care, was that this was a very effective document. It was used widely by reps on the ground to remind employers of the obligations that the Scottish Government expected of them, and a particular clause in it that was actually very widely used by reps was the area around making sure that workers didn't suffer any detriment for following medical advice during their own sickness or absence. So that was something that was used widely.
So is it something that you would consider would be an appropriate thing to agree were there to be any other pandemic in the future, having this sort of framework in place between the government and
yes.
Trade unions? Yes,
I would. I mean, it was agreed very early doors. I believe it was agreed March or April 2020, and as I say, it was something that could be referred to by reps across a range of settings, and empowered them to demand, certain obligations from their employer if they felt they weren't getting anywhere.
Thank you. That document can come down. If I can ask you about some of your specific concerns that you had during the pandemic, of course, staffing is obviously something that is particularly in your mind at all times. But you had, of course, just I think like the TUC raised concerns prior to the pandemic, hadn't you, about the level of healthcare workers within the workforce and vacancy levels. Is that right?
That's right. I believe we produced in our evidence examples of motions that had come to our Congress in 2017, 2018 and 2019, all of which came from healthcare affiliates who were raising concerns around staffing vacancies, lack of adequate workforce planning, and issues around the resourcing of the sector.
There were, of course, some steps taken to bolster the workforce during the pandemic, weren't there, in terms of bringing back workers who'd retired or were unregistered. Do you think those steps adequately filled the gaps?
No, I don't. There was much evidence provided by our affiliates that what was already a bad situation at the outset of the pandemic, caused by, the austerity measures that had been taking place for up to a decade before, were really compounded, and it became a really, really vicious cycle for our members, because we had people who were having to shield and take time off sick through the virus itself, but we also increasingly had workers who were succumbing to burnout, mental health issues, and the more people who were taking time off, the harder it became for our workers who were on the front line to keep their services going. So we had a really acute set of circumstances for a prolonged period that the workers were having to deal with, and that really made the situation extremely difficult, and we just didn't have the resilience and the capacity from the beginning to really allow us to deal with that. So even though extra resources were put in, the experience of our members on the ground was that the situation was extremely difficult.
And that's specific to healthcare.
That's specific. We saw that coming through very highly in healthcare. Yes.
And you touched on some of the other factors that you've mentioned, including, I think, what you phrased as burnout.
Yes.
And so, would it be the case that you consider there's an inextricable link between levels of staffing and burnout, or the impact on the mental health and well-being of those workers?
Yes, there's a number of our healthcare affiliates that carried out surveys over that period that we've touched on in our evidence, and you can see that coming through, that staff having to work excessive hours, that levels of understaffing are, consistently quoted, and that word burnout, 80-90% levels of burnout being quoted in various different staff surveys.
I think within your witness statement, one of the areas you touch on is pharmacists.
Yes.
But was it the case that this assessment in terms of burnout and the impact on all healthcare workers was the case across the board, both primary and secondary care, or were there particular areas where it was more acute?
We had evidence came in from Unite, from the Pharmacists Defence Association, from Unison, from the Royal College of Midwifery, a whole range of different areas. So my observation would be that we were really talking that this was quite a general picture, rather than it being one particular area.
Are you aware of whether there was any national programme in Scotland designed to tackle supporting healthcare workers in terms of maintaining their mental health and well-being during the pandemic, or indeed generally?
I'm not aware of specific programmes within NHS Scotland. However, I have seen evidence that, health and social care was merged by the Scottish Government and integrated in 2016. So some of our surveys cover health workers and social care workers, but my understanding is that certainly in social care there was evidence that there wasn't support. There was a survey carried out by GMB, which is in our evidence bundle, that referenced a real lack of support for workers' mental health. My understanding is that there were some provisions with NHS Scotland, but I'm not familiar with them. You would have to ask them about the specifics of that.
Okay, thank you very much. That's fine. In terms of the wider picture. It's not just, is it about the staff who are suffering? Of course, that's very important, but it's also about the impact that the staff suffering with their own mental health issues may have on patients. Do you, and I appreciate it's quite a difficult question to assess, but certainly from a concern perspective, did you have any concerns that, in fact, mental burnout was having an impact directly on the quality of care that was being provided to patients?
Yes, I think that that's something that came through in the reports back that we were receiving. That was part of the level of stress and concern that our members expressed. They felt that due to the staffing levels, the lack of resources, that they weren't, that added to their burnout, the feeling that they weren't able to give the sort of public service that they would want to care for people. I think that the very nature of the role of caregiving and healthcare workers, there's a lot of emotional investment involved. In fact, it's very important. That human element is a very important aspect of care, and there was real frustrations coming through from staff that they weren't giving their feeling of a high standard of care because of the sheer lack of resources available and the burnout that they were themselves experiencing.
So what's coming through from what you're saying is that this is all linked, really. Staffing levels are linked to mental health issues. Mental health issues are linked to the way in which you provide care, and not being able to provide good quality care can impact on, again, mental health of healthcare workers.
One of our affiliates, Unite, described their members who worked in healthcare as being at breaking point, and that was in, I believe, around August 2020. And I think that just illustrates the level of anxiety that staff had about the provision.
Just moving to a linked topic, but from a slightly different perspective, one of the things that you mentioned in your witness statement is the particular impact on workers from ethnic minority backgrounds. And you cite a report that was done by Unison Scotland in June 2020, looking at underlying inequalities and infection risks, specifically looking at black workers. Mm-hmm. I don't think this was specific to healthcare, but it was looking at specifically the impact on ethnic minority workers, particularly black workers in this report. Yes. Is that right?
Yes, and I think it needs to be seen through the lens that there are high levels of BME workers in health and social care in Scotland. It's a higher level. So it would have been that report would have been reflective of workers in that sector.
And in fact, if we have a look at that, or a section of it, in fact, that's INQ 30215-615. And if we just go to page 3, just can see some of the summarised points that arise from that report. And we can see there that under the heading of black workers and fear, we can see, first of all, that black workers are more fearful of infection. And this was a report, it should be said, done in June 2020.
Yes.
So, of course, then there may be multiple factors contributing to this, but it would probably be sensible to infer that one of the reasons for that fear may have been the higher proportion of deaths among black healthcare workers. Is that right at this time?
Yes, it became clear very early on in the pandemic that there was a really stark disproportionate effect on BME workers that was emerging, and this report was really trying to get at the underlying inequalities that might be contributing to that. And it was I think the report quite clearly articulates that lack of empowerment and worker voice, and that if you're fearful in work in general, or you feel less empowered to raise issues, then that could be directly linked to the higher infection rates. There was more fear about raising issues. There was more fear about asking for appropriate PPE or refusing to carry out duties or citing health and safety protections.
So do you think that there is potentially a link between fear of some of these other aspects, fear of losing your job, more worried about reduced income, a link between that and perhaps the areas in which healthcare workers were required to work which may in fact have been riskier than other areas because those workers didn't necessarily have the confidence to challenge the fact that they may have been placed in particular riskier
Yes,
places.
I think that this is an area we need to look at because it's not only black and ethnic minority workers, but I think that there are definitely socio-economic factors at play when we look at, and this is something that I covered actually in my evidence to the Scottish inquiry on health and social care, so it will be available to yourselves. But you know, that dynamic of workers who are in lower grades, on poorer paying conditions, workers who are perhaps in more precarious work in areas of the care sector, who didn't feel empowered to demand the appropriate PPE, who might not have had as much sight of the appropriate guidance or had it explained to them, or had training to carry out appropriate risk assessments if they were, you know, visiting people in home settings, etc. We think there's definitely a link there that warrants further investigation because people feeling empowered to be able to raise issues is a massive factor. So if you're you know, affected by inequality, you're less likely to feel that empowerment to be able to protect yourself in such a grave situation.
That document can come down. But I suppose following on from what you're saying, do you think that there was a link between the quality and level of risk assessments that were being done and the fear that workers were experiencing, and then again another link to the types of workers who were experiencing that fear?
Yes, definitely. We found that many workers who were being expected to self-risk assess hadn't been given adequate training to do so when visiting people in home care settings, and that would have affected a range of health and social care workers. We also had a range of agency workers, etc., who were not able to adequately access sick leave, and there were real concerns, certainly in the social care side of things, that these workers were, you know, choosing to report for work, you know, rather than be unable to feed their families effectively, and that's a really unfair decision to ask someone to make. So there were some serious issues that we raised at the time with government around these areas.
And I suppose just tying that again back to what we were looking at before, do you think there's a higher proportion of, and in fact I think you may have just touched on it, a higher proportion of ethnic minority workers in more precarious roles,
yes.
And therefore that's perhaps an explanation for why they were more fearful?
Yes, I think if you look at across healthcare and social care settings, we have high numbers of workers from BME communities working in these areas and working in the lower paid jobs in these areas.
And did the STUC take any action to raise these concerns during the pandemic about the lack of risk assessments or appropriate risk assessments for ethnic minority workers?
Yes, we did. We had a number of meetings with the Scottish Government through our COVID group, where the issue of the lack of statistics in relation to BME workers was raised with government, and the need to do more work on this area. And we had general concerns as well around the underreporting and lack of adequate health and safety reporting in healthcare settings and other areas.
And this is something you also touch on in your witness statement, and of course we've just heard from Mr. Rowan, and he touched on the role of the Health and Safety Executive in some detail. One of the points you make in your statement is you say that you weren't informed of the fact that the HSE was pausing inspections of healthcare settings during the initial period of the pandemic. Why would you have expected to have been informed of that?
Well, I think if we had been informed of it, we would have been extremely concerned because we would have, and you know, for us, the healthcare setting at that point was an extremely high-risk area for our members to be working in, and we would have expected enhanced reporting and resources going into looking at some of the issues happening in those areas, not a withdrawal of resource, which was the reality.
I can understand what you're saying about reporting, but can you clarify what you mean about inspections? Because presumably because of the infection prevention and control measures, it was not surprising that there may have been steps taken to reduce more people going into a healthcare setting at the time. Do you think that, notwithstanding the infection prevention and control measures that needed to be complied with, inspections were so important that, in fact, it was necessary to continue those even during peaks of the pandemic?
Yes, that's exactly what I'm getting at there. I think we would have had the view at the time that the opposite needed to be happening. We needed to understand as we were moving forward and learn lessons as we were moving forward in what was a very difficult situation. But nonetheless, that lesson learning was a very important aspect of work that was missed.
And without repeating evidence, you've also spoken about RIDDOR and the requirements under those regulations. I suppose if I could just give you the opportunity to comment on anything further that was said by Mr. Rowan in relation to that, whether you have anything that you'd like to add or anything you'd like to endorse, or anything from a different perspective.
Yeah, I mean, I would very much endorse Mr. Rowan's comments from the earlier evidence. It's our view that there was an under-reporting that was problematic. We actually had a situation where in 2021 we had a dispute with the Scottish Government at a later stage, sort of re-lockdown, where they did not put manufacturing, non-essential manufacturing and non-essential construction back into lockdown, even though we had a really prevalent strain of the virus re-emerging. And we took issue with Scottish Government's policy on this, and they used health and safety executive statistics to push back on us and say to us, well, you know, we don't think there is an issue with work-based infection in these areas because the statistics are not showing it, and we believe that had there been less under-reporting, that you know that wouldn't have been the picture that emerged. So they were pointing to figures that, you know, to back up their arguments that perhaps were skewed because of the under-reporting, and we actually took the TUC report to Scottish Government on under-reporting of RIDDOR when we continued the discussion about these particular sectors, because we felt that there was not enough resources going in across a range of sectors. So I know that's not directly linked to health and social care, but I think it's a good example of, you know, our concerns more generally around the lack of proper reporting.
I'm just conscious that you mentioned the discussions you had with the Scottish Government. Is the issue of RIDDOR reporting a devolved matter or a reserved matter? Do you know?
It's a reserved matter, but the Scottish Government were using that UK information to inform their decision making. So it's very much a reserved matter. And, you know, it is something that we raised. We did have discussions with the Health and Safety Executive around a range of sometimes problem areas with the devolved parts were around public health, you know, public safety in Scotland and public health. And so we did have devolved workplace guidance that we felt sometimes the Health and Safety Executive at UK level weren't really paying much attention to.
And following on from your earlier comments about having a good level of access and liaison to the Scottish Government, of course it's a counterfactual scenario, but if this was in fact a devolved issue, is it something that you think you would have had a better opportunity to challenge the Scottish Government on?
I think that we feel that there was certainly issues with the fact that health and safety wasn't Devolved, we had a situation where there was public safety guidance getting issued and perhaps not getting adequately enforced or taken account of by the Health and Safety Executive, and that was something we felt was problematic.
If I turn now to a separate topic to ask you about, that's the provision of PPE for healthcare workers. You say in your witness statement at paragraph 53, if you want it for reference, that you were aware of reports from trade unions at an early stage of the pandemic that there were issues with staff in healthcare settings getting access to PPE.
Yep.
Do you recall, or are you able to summarise what you think the main issues were in terms of access? Was it one of supply, or was it simply a case of there just not being access within hospitals to the PPE, or in fact just inadequate PPE in terms of the way in which it fit?
I mean, there was a whole range of issues. At the very beginning, there were some really acute supply issues at the beginning. It became then a more complex range of issues. So we definitely had issues with Scottish Ambulance Service at the very beginning, where there was a really acute lack of appropriate PPE. We had people across healthcare settings being asked to reuse, wash and wipe down PPE, buy their own PPE. There was inconsistent supplies. There was sometimes PPE in the building, but it was locked away. There were a range of debates about the type of PPE being fit for purpose. So there was a huge debate around the FFP3 masks being rationed to only certain job roles and procedures, when it was actually felt that aerosol-generated procedures were happening much more widely than the provision of the PPE was being given out for. And there were also issues with ill-fitting PPE and symptoms that healthcare workers were suffering from as a result of that ill-fitting PPE.
Thank you. That's a very comprehensive summary. But if I focus on the first point that you made, that was supply.
Yep.
If we could please look at Jean Freeman's statement. Of course, she was the Cabinet Secretary for Health and Sport for a considerable period of this module's relevant period. And her statement and the paragraph I want to take you to is 24. It's INQ 304934884. If we start with paragraph 24, I just read the beginning of it to you. It says, a unique feature of the distinctive health infrastructure in Scotland, and one which made a significant contribution to the pandemic response, is the existence of National Services Scotland, NHS, NSS. Mm-hmm. Amongst other functions, NHS, NSS acts as a procurement arm for the whole of the NHS in Scotland. If we leave that there and then go on to paragraph 191 of her witness statement, which is at page, I think, 44, she expands on the benefits of NHS, NSS, and she says, 191, as noted, in terms of PPE, we had the advantage of a single procurement arm for the whole of NHS Scotland, namely NHS, NSS, which has a long-standing relationship with providers and manufacturers of PPE. That being the case at the very outset of the pandemic, and despite very high global demand and associated pricing, we were able to increase the volume of PPE on order. So just pausing there and having taken that in, I suppose my question to you is, did you consider, or did you feel that the supposed benefits of NHS, NSS, as they're explained within Jean Freeman's statement, were translated into a good level of access of PPE for healthcare workers on the ground?
So I guess at the outset, what I would say is that we didn't have anything to compare what we were getting to, perhaps what was happening across the rest of the UK. So it's hard to know whether it made a positive difference or not from our perspective. But what I can say to you is that we consistently had a range of issues raised with us, which we raised with government, and I know that these issues were also being raised directly with NHS Scotland and with, across the social care sector as well, where there were definite failures to provide appropriate fit-for-purpose PPE to the right people on the ground. And I think that's the real value that we brought to the table, because you can have all these procedures in place and all the procurement and all the systems, and from Jean Freeman's point of view it might have all looked tickety-boo, but what we were able to inform the Minister of and Government of was that that was not the reality for workers on the ground in far too many cases, and particularly at the start things did get better, but there were still ongoing and consistent issues that took place throughout the pandemic for our workers on the ground.
And you say you informed the Minister, so you informed Ms Freeman at the time of these issues?
Yes, there were early meetings that took place with the Minister, particularly around now. It was either with Miss Freeman or it was with the Fiona Hislop, the Economy Minister, but they're both Cabinet Secretaries. But at a very senior level of government, we were raising issues. There was actually a point at which the Scottish Ambulance Service was about to walk out very early on health and safety grounds, and we had very high-level emergency meetings to get issues dealt with because they just didn't have the access to the PPE they required.
My lady, I'm conscious of the time.
Yes, certainly. I hope you were warned that we take regular breaks for the benefit of those trying to transcribe the proceedings. So I shall return at midday.
Thank you.
All right. Mr. Fireman.
Thank you. Ms Foyer, before we broke, we were just discussing Jean Freeman's evidence, and you were explaining how the levels of supply of PPE may not always have translated into access to PPE for healthcare workers on the ground, so to speak. If we could go back to something that Ms Freeman says in her evidence, and this is INQ 30493-484, paragraph 200. She describes at paragraph 200 something called the PPE helpline, and she says that the Scottish Government set up and managed a dedicated PPE helpline mailbox for HSE staff to contact if they did not have access to the PPE that they needed, or if they had other concerns regarding PPE, and that was set up in April 2020. Was this helpline something that you were particularly aware of, and equally something that you felt that healthcare workers were properly aware of in case they needed to contact the helpline?
So I am aware that there was such a helpline, but I think you'd probably have to ask the health unions in Scotland for more specific examples of how widely used or helpful they felt the helpline was. It was certainly something that was publicised and that we were aware of and promoted, but it was really more done at the level. There were direct discussions between healthcare unions in Scotland and NHS Scotland through STAC and industry leadership groups that took place that the STUC wasn't party to, and I think there's probably better people than myself to comment more deeply on that.
Okay, thank you very much. That can come down in that case. Turning then to a topic which I think you touched on briefly before, in relation to aerosol generating procedures, and you said that there were concerns about that and the distinction drawn between aerosol generating procedures and other procedures. Particularly, I think you're drawing the distinction between areas in which respirators were recommended and areas in which they weren't. You mentioned a particular concern about a specific procedure, chest compressions, not being designated as an aerosol generating procedure. Just to clarify, is your concern that it should have been, in terms of what you were hearing from healthcare workers, they wanted it to be deemed an aerosol generating procedure and it wasn't? Or were there concerns that it was in fact something that shouldn't have been and there was time being taken up putting on unnecessary PPE?
No, the concern was very much that they wanted it to be classified as an AG AFC and
An aerosol
APG, yeah, and it wasn't, and that was something that according to the feedback we received, caused a lot of resentment and a feeling that of unfair practice among the workforce. So it had a bad effect on morale. There were also other areas that the Chartered Society for Physiotherapists raised that they felt key practices they carried out were also aerosol generating procedures but weren't recognised within the guidance as such.
You mentioned you felt this caused resentment. Are you able to explain a bit more about what you felt the effect of not designating these procedures as aerosol generating procedures had on healthcare workers and indeed their trust in national guidance?
Yeah, well, it was very detrimental because we're talking about workers who were already scared, stressed, felt they were putting themselves and their families at risk in going to work every day, and if they felt that they were being denied access to appropriate PPE, that would only intensify that stress.
Okay, and you also describe in your statement I think it's from the RCM saying the Royal College of Midwives,
yeah,
saying that they reported that FFP3 masks had been, or they felt were being rationed. Mm-hmm. Do you see any link between the designation of aerosol generating procedures and that concern that FFP3 masks were being rationed?
Yes, I do, and ultimately I think our preference would have been for access to PPE to be worker-led. We're talking about well-trained, experienced clinicians who should have been allowed to determine in what circumstances they would require the PPE, and there's a difficulty there when if a midwife or a physiotherapist or a nurse identifies that they need that when it's been denied to them through guidance, that we felt shouldn't have been happening. The workers should have had more agency in those situations.
So just to pick up on that, is it your view that there should have been more discretion for healthcare workers to make decisions about what the appropriate PPE was for them to wear, rather
yes,
than it being mandated by national guidance?
Yes, I mean, there's a place for national guidance and we probably would have wanted to see an improvement to it, but ultimately I think we would have wanted to see workers' voices being given a primary consideration in that, and if it was felt to be required, then it should have been provided.
You also mentioned concerns about ill-fitting masks, and is that also with respect to respirator masks, FFP3 masks in particular?
Yes, there were issues raised with our affiliates about resultant skin conditions and issues for workers wearing ill-fitting FFP3 masks, but also there was a gender issue in relation to the default seemed to be that it was fitted for a male face, and that for many women working in healthcare settings, this was a problem that was identified. So it is something that I'm aware that healthcare unions were raising consistently.
This issue about the potentially gendered aspect to it, and indeed, I think you even describe in your witness statement that there was also an issue in terms of ethnic minority healthcare
right,
workers
as
well.
It was a white male face was the default setting, I think, wasn't it?
Yes, indeed.
Is this something which you were aware of, or indeed the STUC was aware of prior to the pandemic, or was this something which, in fact, came to light as the need to use these respirators was increased?
So again, I think that's probably a question for our healthcare unions. It certainly wasn't something that I was aware of the STUC being aware of prior to the pandemic, but I think it's something that during the meetings it became clear to me that this had been a long-term issue that healthcare unions had been raising. I certainly remember a meeting where we had officials from healthcare unions, and that was a topic of the meeting. And that was the inference I took from the discussion at the meeting, that this was not the first time it had been raised, and that it was a long-standing issue that had been raised in the past.
Something that had been raised by healthcare workers in the
Yes.
past, but not something which the STUC had actually taken an initiative in.
No, I'm not aware of the STUC itself as the umbrella body having raised it with government in the past, but most of the detailed discussion around issues like that would not have been a topic for the STUC to raise, because of the very well-established partnership structures that existed between NHS Scotland and healthcare unions. So that's an issue that I would have expected to be raised in those structures in the past.
And just finally on PPE now, you also mentioned, I think, particular concerns about the ambulance service, and you talk about in your witness statement the concerns you had about out-of-date PPE being used. Could you just elaborate a little bit on that?
Yes, there was a case raised by the GMB union, I believe, where there was a whistleblowing case, and they raised the issue that out-of-date PPE had been in use, and the dates had been covered up. So they made a formal whistleblowing complaint in that regard. So I'm aware that that did take place.
Just to summarise, you've obviously given a lot of evidence about a variety of different concerns that the STUC had. Is there anything that we haven't touched on that you think, in terms of looking forward and with a particular focus on healthcare workers, you think there are particular lessons in that regard that we need to learn were there to be a future pandemic?
Yes, I mean, I think that overall, when we're looking at this, there was definitely serious failures by government and healthcare employers to be properly prepared and give the adequate resources and support to workers on the front line during the pandemic. That ranged from, the inadequate staffing levels that we talked about, and the effects that were compounded on staff as the pandemic progressed, the lack of PPE, which we've covered quite comprehensively, the lack of mental health support for workers as the effects deepened, and the real trauma and burnout that was being experienced, the lack of appropriate resources for proper safety inspections and learning to take place as the pandemic progressed. And I think that we need to remember that government and employers have a duty of care to protect the workers that work in our healthcare settings in a pandemic or a serious high-risk situation like that. And we know that the workers who worked in health and social care were disproportionately affected and indeed infected during the pandemic, and people paid the ultimate price with catastrophic effects on themselves and their families. I referred to a report in the Scottish Inquiry from Professor Phil Taylor, which stated that workers in health and social care were 4 times more likely to be exposed than workers in other industries. And our own affiliate, the HSCA's report Never Again in 2022 stated that severe disease, i.e. hospitalisation...
Could you slow down slightly?
Yeah, no problem.
Of the stenographer.
Yeah, no problem. So the HCSA's report stated that severe diseases, and what we're talking about here is hospitalisation or death from COVID, was 7 times more prevalent in healthcare workers. So I think that given all of that, we really need to ensure going forward that these failings are addressed. We need to make sure that there's proper PPE guidance and support put in place for the future. We need to make sure that there is more effective reporting and enforcement of health and safety in high-risk areas. And we need to recognise COVID and long COVID as occupational diseases and ensure that those who suffered detriment through the act of undertaking their work are properly, were properly compensated, are properly compensated going forward, and that these protections are in place so that this can never happen again.
Thank you very much, and thank you very much for that comprehensive summary. Those are my questions. I think there are some...
Thank you, Mr. Fireman. I think it's Ms Mitchell-Casey. I think you may remember Ms Mitchell.
Yes, indeed, I'm obliged, my lady. I think we've asked Ms Foyer a few questions before. Ms Foyer, I act on behalf of Amar Anwar and Company for the Scottish COVID Bereaved. You spoke in your evidence about well-trained staff who were able to complain in relation to PPE and such like. I'd like to ask you about the staff who weren't so well-trained and indeed weren't trained for the purposes or the jobs that they were being asked to do. I don't need to have it up on screen, but at paragraph 29 of your statement, you raise this issue and you explain that there were nurses who were asked to work in intensive care units to deal with critically ill and dying patients when they'd not been trained or properly trained to do so. My question is, did your body complain about this direct to NHS management or the Scottish Government? And if so, what response did you receive?
Thank you. I believe that was our affiliate, the GMB, that submitted that report back to us. And my understanding is that this is something that they had been actively raising during the pandemic. I think if you want, more detail on exactly how that was done, you would need to question them. But my understanding is that that was an issue that was raised, and it had really deep effects on those workers. They have members who suffered PTSD as a result of some of the experiences, but it was a common practice during the pandemic that wards, certain wards were closed, people were redeployed because of the acute difficulties with staff going off sick and staffing shortages. There were lots of areas where staff were redeployed to areas that they weren't well trained on, and it's certainly not an isolated occurrence.
Thank you. My lady, I have no more questions.
Thank you very much, Ms Mitchell. Thank you very much for your help.
Thank you, my lady.
Again, Ms Foyer, I'm very grateful to you.
Thank you.
Right, Mr Fireman.
Thank you. My lady, may I please call Dr. Lisa Ritchie, who will be sworn.
After me. I swear by Almighty God.
I swear by Almighty God.
That the evidence I shall give.
That the evidence I shall give.
Shall be the truth, the whole truth, and nothing but the truth.
Shall be the truth, the whole truth, and nothing but the truth. Thank you. Thank you.
I hope we haven't kept you waiting too long, Dr. Ritchie.
Dr. Ritchie, can you please give your full name?
I'm Lisa Ritchie.
Thank you. Dr. Ritchie, you've given a witness statement to Module 3 dated the 23rd of July 2024. That's INQ 30421939. Can I just check you have that accessible should you need it?
I do.
Dr. Ritchie, you are the National Deputy Director of Infection Prevention and Control at NHS England, is that correct?
That's correct.
And is that a role that was formally referred to as Head of Infection Prevention and Control at NHS England?
That's correct.
And you have responsibility for leading the national IPC team at NHS England as a result of that role?
I do.
Is it right that by background you are a general registered nurse?
I am.
You have a postgraduate diploma in infection control nursing and also a PhD in a specific infection prevention and control matter?
I do.
From 2009, you were a nurse consultant in IPC, Infection Prevention Control, in the Antimicrobial and Healthcare Association Infection Group, RHI, which was then part of Health Protection Scotland, HPS, is that right?
That's correct.
And that Health Protection Scotland, HPS, latterly became part of Public Health Scotland, but not when you were there.
Not when I was there, no. Yep.
And then you began your new role as head of IPC at NHS England in April 2020. Is that right?
That's correct.
During this module's relevant period, that is March 2020 to June 2022, you were a member of various scientific subgroups, including NERFTAG, the UK IPC cell, which we'll come to in a moment, and the hospital onset COVID-19 infection working group. Is that correct?
That's correct.
As I said, the majority of your evidence is focused around your role in the UK IPC cell, which you chaired for a period, I believe, between June 2020 and the end of March 2021. Is that right?
To June 2021.
To June 2021.
It's a year.
Okay, for a year. I'm going to ask you some questions about the IPC cell, but before I do, my lady, it's been said before, but it does bear repeating, this witness was not the only individual who was on the IPC cell. She acted as the chair of the cell for a substantial period, which the inquiry is examining, but she's, as a result, one of the most appropriate individuals for the inquiry to question. But of course, some of the time, she may be referring to decisions that were made collectively. And in fact, Dr. Ritchie, if I could ask you to make clear where relevant, if you are speaking from a personal opinion, a personal professional opinion, or indeed the opinion which was reached from the UK IPC cell as a whole.
Okay.
In terms of that cell, it formally started meeting, I think, in early February 2020. Is that right?
That's correct.
And did it evolve from NHS England's own IPC cell, which was part of its emergency preparedness, resilience and response unit?
That's correct.
It may have varied, but how regularly did the UK IPC cell meet?
So when the NHS England IPC cell was stood up, which was part of a number of cells under the Emergency Preparedness and Resilience for NHS England, I was not working in NHS England at that time. So my predecessor, who was the head of IPC, invited the other UK IPC leads from Scotland, Northern Ireland and Wales to join the IPC cell meeting of NHS England, and that evolved into what became known as the UK IPC cell.
Thank you, that's very helpful. You summarise the purpose of the UK IPC cell as being to provide a UK-wide consensus on issues relating to infection prevention and control, and of course that includes, perhaps most pertinently, the use of PPE.
So the cell did not advise specifically on PPE, so the role and purpose of the UK IPC cell and for NHS England was to come together to agree consistency on infection prevention control guidance, so that we had standardisation across the 4 nations. So that was our purpose, to make sure that when we were drafting guidance, that was aligned with WHO and the scientific evidence that was emerging.
You acknowledge, of course, though, that PPE falls within infection prevention and control as a relevant issue.
It does indeed, but it is one part of a very complex number of IPC measures.
Just focusing, if we can, on the actual concept of having an IPC cell in the first place, are you aware of whether or not this featured in any specific pandemic planning documents, or in fact whether it was something that was thought up as the emergency was convening? I appreciate you've spoken about the way in which it developed, but the actual necessity to convene a cell, was that something that was always within pandemic planning, or was that in fact just something that was put together as the emergency was developing?
I believe it evolved. It did evolve as the emergency developed. I mean, I think what would have made a real difference to me as a new start in NHS England on the 1st of April would be having a clear structure, outlining the functions, the roles and responsibilities of key national organisations, and understanding what the governance, the decision-making processes and the primary knowledge resources, evidence bodies and guidance leads would have been invaluable. So in hindsight, it would have been very useful to have understood or known what that structure was, and maybe something for the future.
And we'll come to the structure of the cell in due course. But before we do so, can I just ask you about the members of the cell and who was represented on it. You listed them out in your witness statement at paragraph 134, and they are NHS England, Public Health England, which then became the UK HSA, Public Health Wales, High Scotland, the Scottish HAI unit, the Association of Ambulance Chief Executives, and the Department of Health and Social Care. Can I clarify, was membership of the cell then specific to those organisations rather than to any specific individuals?
Yes.
The inquiry heard from Richard Brunt of the Health and Safety Executive last week, and he talked about having a direct input to the cell. You didn't mention in your witness statement them being a member of the cell. Is it right they weren't actually attending cell meetings, but they did have direct lines of correspondence to those who were on the UK IPC cell?
Yeah, that's correct. So HSE was not a member of the UK IPC cell, but we did engage with HSE on many issues.
You were a member of the cell both at Health Protection Scotland as a representative of Health Protection Scotland and then subsequently as a representative of NHS England, is that right?
That's correct.
One of the things that was mentioned by Dr. Barry Jones of the COVID Airborne Transmission Alliance on Thursday when he gave evidence was he said that there were more members on several occasions attending these cells from NHS England than any other organisation. Sometimes he said there was up to 20. I don't know whether that's accurate or not, but dealing with the issue of why there may have been more members from NHS England attending these cells, is it right that NHS England bore the secretariat function for the cell and would therefore sometimes have had more members attending to take notes, etc., or were there other reasons why they may have had more members attending?
So because the UK IPC cell had evolved from what was the NHS England IPC cell, we did continue, we had the infrastructure and we had that cell in place, so we continued to manage the cell in terms of organising meetings and doing the minutes and action notes from those meetings. In terms of membership from the representative organisations, it was down to those other national organisations to bring to the meeting who they wish to represent their country, public health body, RHI, Scotland from Public Health Wales. So there was no bar from those organisations by the chair or anyone else about who from those organisations could attend those meetings.
So it goes back to the point that we were speaking about earlier, that it was the organisations which were represented on the cell rather than specific individuals.
Correct.
You could have sent many more individuals if you wanted, or much fewer.
Indeed.
Are you able to recall, and I appreciate that to some extent you may not know in detail the qualifications of absolutely everyone who attended every single cell meeting, but are you able to recall whether or not there were individuals from non-medical backgrounds or non-clinical backgrounds, for example, engineers or physicists or physical science experts who attended the cell?
So predominantly the membership was clinical and probably nursing, I would say, more than medical. And I think that was appropriate for the function of the cell and the role and purpose of why we had been established, given the expertise that we had in infection prevention control. We did not want to duplicate the efforts of other meetings, and we were aware that there were many meetings happening at the same time. For example, there was an engineering management group that was a subgroup of SAGE, and we would obviously look to the outputs of such groups and review what we could translate from the outputs of those meetings into the IPC guidance if it was relevant.
I appreciate that you have said that it was appropriate, but the inquiry heard last week from Professor Beggs, who comes at things, I think, from a physical science perspective, and it was his view that in terms of the science associated with transmission of infectious diseases, there's been a bias towards epidemiological evidence over physical science. I don't know whether or not you agree with that at all, or if you disagree. Perhaps I'll give you an opportunity to comment on that.
Can you repeat the question again? Sorry.
Professor Beggs told us that he considers that in professional infection prevention control spheres, there's been a bias towards focusing on epidemiological evidence over considering what the physical science may say, and as a result, a more narrow picture has been obtained. So my first question is do you accept that criticism?
No. I do think there has been a lot of studies now being undertaken by physical scientists and others, but I think from an IPC perspective, we would follow the epidemiology and the scientific literature in terms of the infection prevention and control guidance that we would put together. So we would be taking the views of our scientific experts, be that from SAGE, UKHSA, Public Health England.
So you don't think then, on reflection, that perhaps the cell would have benefited from having the expertise of a physicist or an engineer or someone from that background?
There's always room for improvement. And in terms of the different backgrounds, maybe that is something for future, a lesson learned. That some of these organisations, it's how they're plugged in. I suppose it goes back to the structure, doesn't it? And how they fit in under the Civil Contingencies Act, for example, if they were a responder under that remit or within that structure. So I'm not saying that, I think what I am saying is the UK IPC cell evolved over time, and the membership was specific to the role that we were carrying out, that it was the infection control leads with the expertise in infection control that were pulling together the evidence, taking the outputs from SAGE and ERTAG, translating a lot of the science into practical guidance for frontline staff. But if the membership is something that we need to review, there's always lessons to be learned.
Thank you. The one area then I suppose that you would confirm you were on top of, from the perspective of the representatives of the UK IPC cell, was having direct involvement in clinical work. Is that right?
That's correct.
So there were members who were actually directly involved in putting into practice the guidance that was being formulated.
Yes.
Another issue that has been raised with the inquiry is that of stakeholder engagement. On reflection, I appreciate you've been very candid about the potential benefits of physical science and engineering. What about the fact that there were concerns from the Royal College of Nursing and the British Medical Association about them being engaged? On reflection, do you think there would be benefit for any future IPC cell, if it was convened, to have a representative from one of those union organisations attending?
It felt like there was a couple of questions in that. I think, first of all, in terms of stakeholder engagement, we were working at pace. I know that as individuals and collectively as an IPC cell, we were seeking feedback and making ourselves available to people to give that feedback. In terms of the updates to the guidance, there were often times where I would make a phone call to RCN or to the Infection Prevention Society or the president of other organisations to say that we had to get this guidance out quickly, but if I sent it over, would they have a look at it and come back with any concerns? So we were working at pace, so it was often difficult to take stakeholder feedback. When there was what we would consider major changes to the guidance, so when we changed the guidance for remobilisation, when care pathways were brought in to get the NHS back up and running, and equally when we were preparing winter guidance for 2020 to 2021, we did more formal consultation. So stakeholders were involved in that process because we had a bit more time to get the feedback and take their input. I know that my Chief Nursing Officer and other colleagues were out and about, and they had direct contact with Royal Colleges, with very many meetings. We put on lots of webinars.
Can I just pause you there and just ask you about the principal basis for my question, which was, what about having a representative regularly attending the UK IPC cell from the Royal College of Nursing or the BMA?
I think the challenge is the number of different representatives from all of those various groups. So I think it's important, and again, I think it goes back to the structure about setting that in place, about how that what the consultation looks like, what is the communication and engagement strategy, and having something like that proactively built in, rather than it being something reactive. And I accept that, you know, it wasn't always easy to take all of the feedback that was coming from stakeholders, given the pace at what we were working.
I think that then leads on to the criticism which the inquiry heard last week about the suggestion that from some of the members of the BMA and Royal College of Nursing, they felt like they were being managed and pushed away. I presume that based on what you've just said about stakeholder engagement and the steps you did take to consult, you would at least make clear that wasn't your intention, and indeed probably not what you consider actually occurred. Is that right?
Yeah, absolutely. And if that was the perception, it couldn't be further from the truth, because we did want to get feedback from people. But as I say, when we were pulling or drafting guidance and reviewing the evidence and updating, we were working to very tight timelines.
All of these points are relevant, of course, because what I want to ask you is whether, in fact, you consider the membership of the cell as it was during the pandemic, the COVID-19 pandemic, was sufficiently broad to ensure that a range of expert opinion was brought to the table. Do you consider that was the case?
I do.
One of the points which arises from review of the IPC minutes is this concept of the cell reaching a consensus. Can you explain what the process was by which the cell reached a consensus and then made a decision on how to proceed?
So it was as chair, when I was chair, and as a member, the decision making did rely on consensus. It was ensuring that we had broad agreement among the members, though not always unanimous. And we provided recommendations to national governance bodies, to each of the countries for their final approval. So it was making sure that we had open discussion, I'd say that we came to a recommendation at the end of that, which would be broad agreement, and those, if there was any doubt or we didn't feel that we had come together and reached consensus, then that would have been escalated to senior clinical colleagues.
I sense from what you're saying then that there weren't actually formal votes taken during the meeting.
No, there was not.
So then did it rely essentially on whoever was chairing the meeting, in many of the instances you, getting a broad flavour of what the discussions were and then summarising that as the consensus?
Yes.
If we can then look at one of these documents that's relevant, which is the minutes of the IPC cell from the 18th of August 2021. This is INQ 3039886, and it's the third I think it's the third page of that document. If it could come up on screen, please, if possible, but don't worry if not, I can just summarise what you say. In August, you say that you were still working with a consensus view. However, escalation of any disagreement may need to be included in the next terms of reference. So this is in August 2021, sometime into the pandemic, and it seems that still at this stage, the terms of reference and the lines of reporting were still being ironed out. Is that a fair summary?
I mean, we did review the terms of reference for the duration of the cell. I mean, I think it's important to say here that we could have been disbanded at any time. The cell was given authority by others. We didn't have a direct route to publication. The guidance could have been pulled that we put out, or the consensus decision could have been pulled by any of the public health bodies across the UK. And I'm sure our senior leaders would have been clear about the decisions that we made, whether they were right or wrong.
So to be absolutely specific, I know you mentioned public health leaders, but who would any disagreement or any ambiguity have been escalated to? Who were the individuals or professionals who would have had oversight of that?
To the UK senior clinical leads
In which departments?
in each of the 4 nations.
And in a related question, would that mean then that Public Health England, for example, who published the guidance on behalf of England at least, would they have had the ability to have come back to you on anything that was agreed during the IPC cell minutes and say objected to it or required an amendment to be made to that piece of guidance that was proposed?
Yeah. As the lead organisation for public health and infection control in England, they could have come back at any point and made amendments.
And would this still apply if Public Health England themselves, who are obviously members of the IPC cell, had not in fact agreed with the consensus view that was reached at the IPC cell meetings?
Yes.
Can you recall any occasions on which, whether that be the CMO within each nation, the CNO within each nation, or public health bodies, actually came back and said, you need to make a change to this guidance, or we're not going to approve it in its current form?
Yeah. So I don't recall specifics, but I do recall conversations with Public Health England colleagues on draft guidance content.
In practice then, I appreciate that you may not have been responsible for the reporting lines, but in practice, was it the case that recommendations reached at the UK IPC cell were routinely incorporated into national guidance?
That's correct.
The inquiry has been provided with several of the UK IPC cell minutes, indeed I think all of them now. I think that's clear, but the minutes weren't actually published and don't think they ever have been published. Why is that the case?
The decision not to publish the minutes was never formally addressed. As I said at the beginning, the UK cell, IPC cell, evolved from what was the NHS England cell, and none of those incident cells were publishing minutes. So our primary focus was on producing timely, evidence-based guidance that aligned to national and international recommendations. But I think had the conversation come up, I don't think there would have been any objection to publishing the minutes, but it wasn't something that we formally discussed.
Were there ever any requests from, as far as you can recall, any union bodies or any other campaigning groups to publish the UK IPC cell minutes?
During the relevant period, I don't recall.
Again, trying to take a forward-looking approach, do you think there would be benefit in publishing these sorts of minutes to allow for a dialogue of challenge to come to the surface?
Yes, I mean, I think if publication of such minutes would be helpful, it might be an area that requires to be formalised across the 4 nations of the UK.
Thank you. If we can now turn to some key principles of infection prevention and control to try and establish some of the things that you were looking at as a cell and considering. You've set out in your statement, and the inquiry has heard about standard infection control measures, and that's measures that I think are taken all of the time for all healthcare workers, regardless of the threat that is being faced and regardless of the transmission of any particular virus, but to protect against generally all threats. Is that right?
That's correct.
We then have transmission-based precautions, and this is relevant to the nature of the disease that you're trying to protect against, isn't it?
Yeah.
In order to properly protect against a virus, you need to understand the way in which it's transmitted, and thereafter you need to prepare for and provide for the relevant protections that will protect against the way in which that virus is transmitted.
Correct.
We've heard about, and you set out in your statement, the 3 established routes of transmission for a respiratory virus: contact, droplet, and aerosol. Focusing, if we can, on droplet and aerosol, because those are the 2 most pertinent here. You would agree, I suspect, that there are differences in terms of the precautions you need to take when protecting against a virus spread via droplets and one which is predominantly spread through aerosol transmission.
Yes, and it does support the intervention. The definition supports the IPC measures that would be put in place.
I'm not sure. Sorry, could you clarify what you just said?
So sorry, could you repeat the question?
The question is a basic one, really. It's just to establish that there are differences between the way in which you protect against a virus that is spread predominantly by droplets and one which is spread through aerosols.
That's correct.
And that's why we've heard about the differences between fluid-resistant surgical masks and respirators. Respirators being necessary for aerosol protection and surgical masks for droplet protection. You accept, I think, that FRSMs, if I can use that acronym, don't protect against aerosols, do they?
No.
And we heard last week from Richard Brunt, who explained that from the HSC's perspective, FRSMs aren't in fact deemed to be PPE because they're not, if I can summarise, personally protective. They are, I think, source control or a medical device as far as he's concerned. They're regulated by the MHRA. You say in your witness statement at paragraph 68, for reference, that you do think that FRSMs are considered to be a component of PPE. Can you accept that because of the issue in terms of them not being approved by the HSC as PPE, that some may not consider FRSMs to be PPE?
FRSMs have been used in infection prevention control in healthcare settings for a long time and are part of established guidelines nationally and internationally, the WHO, communicable disease centres in America. So as PPE, they have been cited as part of infection prevention control precautions for many years in many guidance documents. So it's a well-established piece of infection prevention control kit, or PPE.
When dealing, of course, with a virus that's spread through droplets.
Correct.
In terms of the difference between the two modes of transmission, aerosol and droplet, the inquiry heard last week about historically this having come down to size of the particle. Of course, we also heard that larger droplets behave ballistically and fall to the ground relatively quickly, whereas aerosols float and remain in the air for a much longer period of time. Do you agree with that summary?
Yes.
Can we please have a look at your paragraph 49 of your witness statement? And this can come up on screen. It's paragraph 49, page 14. You say this: "It's my view that the distinction between a respiratory aerosol and droplet in terms of size, micrometers, is an academic consideration that cannot be usefully applied in national guidance or by healthcare workers in real clinical environments." And you then give your reasons for that, including how difficult it is to measure a particle in practice.
Yep.
Can I just try and clarify what you're actually saying here? You aren't suggesting, are you, that in fact a healthcare worker would need to take a moment and try to assess the exact size of a particle that's just been emitted, because of course that would be impractical. But it is the case, is it not, that it's important that those who set the guidance understand the difference between the size of particles, because that then informs the guidance that you set.
Correct. Yep.
So when you say academic distinction, it's not fair, is it, to call it simply academic, because the understanding is directly relevant to the guidance that's then used in practice.
I think I was meaning academic in the sense that research that is done in laboratory conditions or in academic institutions then has to be translated into practicable IPC guidance. So understanding a cut-off point is helpful, and having a definition, again, which has been long established in infection prevention and control guidelines, be it contact, droplet or airborne transmission, have been the known and established IPC transmission measures that have been in the guidance for many a long time.
So you do accept that there is use to it. You're drawing a distinction between the scenarios in which it's useful.
Yes.
Okay. Professor Beggs gave evidence last week about the size of microns that he considers to be aerosols and that he considers to be droplets. And the cut-off point he gave was 100 microns. He says anything less than 100 microns is an aerosol, and anything above that is a large droplet. I suspect you don't necessarily agree with that. Is that right?
I respect that that is Professor Begg's opinion. I am not a physical scientist.
So you aren't in a position to say what your view is on the size of particles and the distinction between aerosols and droplets?
I think the distinction I would say is that airborne transmission occurs by small droplets, aerosols, or particles that remain suspended in the air, and that the airborne transport of those particles may carry pathogens long distances, unlike droplet, which involves larger size droplets that requires closer contact for transmission to happen.
It might be helpful if we look at this in practical terms and consider how this was then translated into healthcare infection prevention and control guidance. If we could go to INQ 30251-675, this is a passage from some of the guidance. It's page 13 and 14. It should come up on screen soon. Yes, here we go. If you look at the bottom part of that, it says droplet precautions, and it says used to prevent and control infection transmission over short distances via droplets, and there it says above 5 microns. So just to clarify, this guidance, is this likely to have been something that was formulated or agreed upon in an IPC cell meeting?
No, this guidance existed well before that.
So is this guidance, which was the guidance that was adapted from the pandemic influenza guidance?
Even before that, I think back in 1997, HICPAC, which is an advisory group to the WHO, came up with these routes of transmission, contact, droplet and airborne transmission, and they described these droplet sizes.
And those droplet sizes, as they were described all the way back then, have maintained and made their way into infection prevention and control guidance, including the guidance that was issued during the pandemic.
That's correct.
And so it is the case, isn't it, that for the purposes of the guidance that was issued during the pandemic, the cut-off point was deemed to be 5 microns, which is obviously markedly different to the cut-off point that Professor Beggs uses.
Indeed.
Can I just ask you a question, Dr. Ritchie? Things that are well established aren't necessarily always right. Science moves on, understanding moves on. Were you aware of any debate about the size of droplets and whether the science had moved on or understanding had moved on?
I think as we came through the pandemic, those discussions were taking place, and scientific individuals were putting those cases forward. At the beginning of the pandemic, that wasn't the case.
I suppose, thinking about it in practical terms, if we go back to those cut-off points, if we look at a section, I can take us, please, to a section of Professor Begg's report. This is INQ 304744276, page 48 and page 49, paragraph 122. He summarises here what he considers to be the issue as a result of different spheres using different cut-off sizes. And he says, well, one of the unintended consequences of the inappropriate, that's his words, 5 micron threshold was that scientists from different disciplines use completely different terms to describe the same objects. So, for example, a 12 micron diameter respiratory particle might be called a droplet by clinicians and microbiologists, whereas the same object would be an aerosol particle to an engineer or physicist. So is that, Dr. Ritchie, the nub of the distinction between the two disciplines, and indeed a potential cause of concern where you have the established science as it was in the infection prevention and control guidance, and in fact another reasonable body of scientific evidence that says, in fact, you're describing these particles in the wrong way, and as a result of that, you're devising infection prevention and control measures that are incorrect.
Yeah. So I think the challenge for us was to translate a lot of this scientific evidence into infection prevention control guidance. And I respect, as I say, Professor Begg's view, and acknowledging that transmission can occur along a spectrum and airborne is possible. I'm talking about airborne generating procedures. That airborne spread is possible, particularly in crowded and ventilated settings, but the epidemiology and the scientific literature did not support that airborne spread as the predominant mode of transmission, and indeed the WHO guidance has not stated a change in a predominant mode of transmission for SARS-CoV-2.
But is that using the 5 micron cutoff or the 100 micron cutoff?
The WHO have recently looked at and published revised terminology for respiratory viruses, and that's still, I don't think they've spoken about a continuum now, as I've just said, and the cutoff, I think, is part of a risk assessment.
Okay, I'm just struggling to follow, because I think ultimately the question would be, it could have been that both you and Professor Beggs agreed entirely on the size of the particles that were causing the infection. You both look at a 12 micron particle, but he says that's aerosol transmission, and you say it's droplet transmission. And as a result, you say airborne transmission is not predominant because we've got 12 micron particles, which are droplets.
Yeah.
When you say that airborne transmission has not been recognised as being predominant, do you know on what basis you're saying that with respect to particle sizes, or are you not able to say that?
I'm probably not able to say that in terms of particle sizes, but in terms of the epidemiology and the scientific literature and the outputs from those scientific groups that we were taking advice from.
I suppose trying to follow this up then, just to tie things up, those scientific groups that you were taking advice from saying that airborne transmission was not a significant threat, were they doing so on the basis of a 5 micron cutoff? Do you know that?
I don't know that.
So can I just make sure I've understood? I thought you said just a moment or two ago that the World Health Organization has not even now said that aerosol transmission is the most dominant route. Is that what you said?
Yes.
I thought they had.
They haven't changed their guidance.
I'm not sure if they said most dominant or if they've just acknowledged it as a route. Would you know the answer to that, Dr. Reid?
They've acknowledged it as a route, but they've not said it's
that's
the
the
dominant
difference.
mode of transmission.
Thank you, I had misunderstood.
Apologies.
Thank you. No, it's my fault, I had misunderstood.
I suppose this leads on to a point you make in your witness statement, which is that you say that the established modes of transmission as defined before the pandemic, i.e. with specific infectious particle cutoff sizes, it is in fact not as delineated as first thought prior to the pandemic. I suppose, first of all, what do you mean by that?
So I again accept that airborne spread is possible, and I think what we learned through the pandemic was that rather than these distinct cut-offs, that there was more of a spectrum of airborne spread was possible. So having distinct cut-offs probably now is not a helpful thing to have. And I think there's been many reports of nosocomial infection, like hospital infections, where other routes of transmission can't be ruled out.
That can come down, that document. I suppose there are two questions which arise from that. The first is, if that is the case, and that's the view you've come to now, when did you come to that view?
Could you repeat the question, sorry?
I think you said that you accept that there are multiple routes of transmission. Airborne was possible. There's a spectrum of different ways in which a virus can transmit, if I'm summarising what you said, I think. Yeah. So I suppose what I'm asking you is, when did you reach the conclusion that that was in fact the appropriate way to assess the risk?
I think when the cut-off measures of the particle sizes were not seemed or deemed to be helpful within clinical guidelines, and that the awareness of airborne transmission became more apparent.
Can I push you to try and identify a time frame?
I don't recall.
Was it during this module's relevant period of March 2020 to June 2022, or after it?
Probably more towards the end and after.
Just to tie this area up before we break, does your understanding that things are perhaps more nuanced than was previously considered to be the case, and that in fact there's a spectrum, does that not reinforce the need to protect against a variety of different modes of transmission, and perhaps be more precautionary and protect against all of them at once, rather than just be specific and say this is the way in which it's transmitted?
Indeed.
Thank you. My lady, I don't know if that's an appropriate time. If
Yes, certainly. I shall return at... I hope you were warned that we would be taking lunch break. Thank you. I shall return at 2 o'clock. All rise.